Everyone, and welcome to our lesson about the gastric fluid. So, gastric fluid analysis is seldom requested in the laboratory because the collection of the said fluid is complicated and it poses a lot of discomfort on patients as it involves the use of intubation tubes. The gastric fluid analysis is done for the following reasons. First is to determine if a patient can secrete gastric juice, which is HCl or hydrochloric acid. So, this is an acid in the stomach that primarily functions in the digestion of food. Second is to measure the amount of acid produced by a patient. Note that any excess or deficiency is associated to a certain condition. Third is to support diagnosis of hypersecretory state characteristic of Zollinger-Ellison syndrome. A hypersecretory state means that there is increased amounts of gastric acid due to a certain disorder. So in this case, the disorder is Zollinger-Ellison syndrome. Fourth is to determine the completeness of vagotomy. So, vagotomy is a surgical removal of the vagus nerve that connects the central nervous system and the digestive system. Lastly, is to aid in the diagnosis of gastric ulcer and duodenal cancer. These cancers can occur when hypersecretory state, like what happens in the Zollinger-Ellison syndrome, is left untreated. So we will discuss more about this condition later on. For now, let us talk about the macroscopic examination of gastric fluid. So, the color of the gastric fluid of a patient that is on a fasting state is normally pale gray or simply gray with mucus. So, why is there mucus? Because the stomach lining is coated with mucus, and this mucus protects the stomach from its acidic secretions. So, without this protective layer, the stomach could be damaged and develop ulcers from the acid. Moving on, the normal volume of gastric fluid on a fasting patient is 20 to 50 ml. Take note that is 20 to 50 ml. Before we proceed, let us take a moment to familiarize ourselves with some key terms that we may come across in our lecture. So these terms are actually simple terms and it all refer to HCl production, which can be easily determined or defined using their prefixes. So first we have euchlorohydria. U means normal or good or okay, while hyper means increased, hypo means decreased. The A or the A in achlorohydria means absence, so no HCl. Also for the an in anacidity, it also means absent, so no acid. Notice that both the hypo and chlorohydria have gastric pH that is greater than 35. So how do you differentiate the two? In hypo, the pH of 3.5 falls after gastric stimulation, meaning it gets acidic. It becomes less than 3.5 because in here you still have the acid HCl. It's just that the acid is decreased. While in achlorohydria or achlorohydria, their pH that is 3.5 does not fall after gastric stimulation because you don't have acid or acid stores here anymore. So, regardless of how many chemicals are introduced, the stomach will not produce acid since it lacks any acid reserves to begin with. Okay? So, the terms hypo and achlorohydria can be confusing and also they are no longer commonly used. Instead, the term anacidity is now used to refer to pernicious anemia. So, anacidity is defined as the inability to produce a pH of less than 6 or lower following gastric stimulation. So, meaning, since it is an inability to produce less than 6 pH, that the pH is always greater than 6. And if the pH is greater than 6, is that acidic or no? No, it is not acidic because it is already above 6. Thus, the term anacidity, meaning no acid, not acidic. Okay, so please keep these terms in mind to help you understand and follow the rest of our discussion. Now, let us proceed to gastric acid secretion. When we eat food, of course, they will go to our stomach, and these foods will stimulate the G cells of the stomach to produce gastrin. So, in the presence of gastrin, we have cells called the parietal cells, which will secrete HCl. So, in short, the gastrin will stimulate the parietal cells to produce HCl. So, now that we have HCl in the stomach already, which can help in the breakdown of food, do you think that this HCl is enough to break down all the foods that we ate, including the proteins from meat? No. So, as you know, proteins are big and the intestines cannot absorb them unless the proteins are broken down into amino acids. So, to do so, the stomach have chief cells which secretes pepsinogen. So, since pepsinogen is still inactive, okay, it needs HCl so that it can become pepsin, which is the enzyme active. So this pepsin can now break down and digest proteins. So the proteins are turned into smaller polypeptides and then into amino acids for better absorption. Okay, so this is the normal process, and we need all these cells, acids, and enzymes here in this diagram so that the stomach can absorb the nutrients from the food that has entered into your system. So, in this topic, we're also going to talk about two conditions related to this process. We have the pernicious anemia and the Zollinger-Ellison syndrome. So, first, let us go to pernicious anemia. Pernicious anemia is an autoimmune disorder characterized by having not just one but two autoantibodies called the antiparietal cell antibody and the anti-intrinsic factor antibody. So we will focus first on the antiparietal cell antibody. So let's go back to the diagram earlier. For example, a patient has pernicious anemia. So since it is an autoimmune disorder, there's antiparietal cell antibody that has been produced. This antibody will bind to the parietal cells and it will destroy the parietal cells. Since the parietal cells are now destroyed, the HCl can no longer be produced. And that is the characteristic of pernicious anemia. There is absence of HCl production, which is called the achlorohydria or an acidity. How about in Zollinger-Ellison syndrome? So Zollinger-Ellison syndrome or ZES is a malignant disorder. It is characterized by having a tumor in the pancreas. So this tumor is the non-beta islet cell adenoma of the pancreas. Adenoma is a gland-like tumor and it produces gastrin. So since it is a tumor, it is expected that it is abnormal. So there is an abnormal production of gastrin, meaning there is increased gastrin production, and that is the first characteristic of ZES, increased gastrin. So let's go back to this diagram again. Like we said, in ZES, there is a tumor in the pancreas, and this tumor in the pancreas produces gastrin. So remember that the gastrin stimulates the parietal cells to produce HCl. Since there's too much gastrin in ZES, more will stimulate the parietal cells to produce the acid HCl. So meaning more acid is produced. And thus, this is another characteristic of ZES, increased HCl. So again, increased gastrin and increased HCl, which is called hyperchlorhydria or hyperacidity. Okay, so we have here the summary of the two conditions that we just discussed. Pernicious anemia is an autoimmune disorder. Since it is autoimmune, it produces autoantibodies, namely antiparietal cell antibody. So this antibody will destroy the parietal cells. And since the parietal cells secretes HCl and they are being destroyed in pernicious anemia, meaning that there is no HCl produced. Thus, the term is achlorhydria or anacidity. While in Zollinger-Ellison syndrome or ZES, it is a malignant disorder. It is characterized by a tumor in the pancreas. So this adenoma produces gastrin. So meaning there is increased gastrin in ZES. Since gastrin stimulates the parietal cells to secrete HCl, and there is many gastrin in ZES, it means that more parietal cells are stimulated and will result to a production of more HCl. So in ZES, there's increased gastrin and increased HCl. The term for this is hyperchlorhydria or hyperacidity. Okay, so let us have a quick review. Cells that secrete HCl. Okay, the answer is parietal cells. Hormone that stimulates the parietal cells to secrete HCl. That is gastrin. Cells that produces the pepsinogen. Okay, the answer is chief cells. Now let's move on to specimen collection. So the collection of gastric fluid is through gastric aspiration using a nasogastric tube or the NG tubes. So there are different types of NG tubes such as lavaquator, Ewald's, and the Edlich tubes. But the two common types are the Levin and the Rifas tube. So if Levin tube is used, the tube is inserted through the nose, while if Rifas tube is used, the tube is inserted through the mouth. Okay, so like here in this picture, the tube is inserted through the nose, and the tip of the tube is here in the stomach. So it will aspirate the acid. Acid will go here, and then the acid is collected. Okay, so to easily remember that Levin tube is inserted through the nose, notice that the spelling in Levin has letter N and the nose also has letter N. While for Rifas, there is letter U in the spelling and mouth has letter U. Okay, so all the other tubes are inserted through the mouth. Number 2 and 3, all of them are inserted through the mouth. Only Levin tube is inserted through the nose. Okay, so after the acid is aspirated, the following are to be determined. We have the BAW and the MAO. The BAW stands for the basal acid output, while the MAO stands for maximum acid output. So first, we have the BAW. The word basal means in the morning. So usually, if in the morning, that is fasting state or from sleep. So this means that the BAW is the total gastric secretion during unstimulated fasting state. So to simply explain, it is the gastric acid produced by the stomach when the patient still has no food intake or if the patient is in fasting mode. That is why if you noticed when you get hungry or you don't get to eat, your stomach feels like it is boiling, right? And that is because there is gastric secretion. Okay? So how long is the collection in BAW? The routine is 1 hour, but this 1 hour is divided into four intervals. So that is collection or aspiration every 15 minutes. For example, first 15 minutes you aspirate and then you stop. Then you wait for another 15 minutes, you aspirate and then you stop until you have completed four aspirations. Okay, so a single 1 hour collection can also be done, but um, that is not commonly done. Okay, so what is commonly done is the 1 hour with 15 minutes interval. So for other tests, such as insulin hypoglycemia test, a 2 hour collection is done. So after aspiration of gastric fluid for the bowel, the patient will be injected with a chemical. And once the chemical is injected, the stomach will produce an acid. And this acid that is produced after the injection of that chemical is called the MAO, or the maximum acid output. So how long is the collection for MAO? It actually depends on the chemical that has been used or has been injected. For example, if pentagastrin and histamine are used, so that is 1 hour collection with 15-minute interval. While if insulin is used, then that is 2 hour collection. So there are three methods for a stomach to produce gastrin. So we have here the gastric stimulants. First are the test meals. So in this method, you just have to eat. Okay, examples of test meals are the EWALDS, BOAS, and Rigels. So in EWALDS, the patient will eat bread, water, or quick tea. While in BOAS, the patient will eat oatmeal. And in Rigels, the patient can eat beef steak or mashed potato. So which of these tests do you think might trigger the stomach to produce more acids? Naturally, it would be the one involving the tastiest foods, right? Such as beef steak. So, have you ever noticed that when you are enjoying tasty food, you tend to eat more than usual? This happens because the stomach gets excited and it releases more acids. So, with an increase in acids, the food is processed quickly, allowing you to keep eating and eat and eat and eat. In contrast, if the food is not tasty, so your stomach doesn't get excited or doesn't get stimulated, and it does not release as many acids. So as a result, the food takes longer to process because there's not much acid, and so you feel full more quickly. So aside from eating, another way of gastric stimulation is through chemicals. So you just have to choose any of these chemicals to be injected to the patient so the stomach can produce acid. Among the four chemicals, pentagastrin is most preferred. Why? Because it is also a gastrin, or it resembles the gastrin produced by the G cells. Next, insulin. It is used to assess vagotomy procedure. So again, what is vagotomy? It is the surgical cutting or removal of the vagus nerve. So this nerve signals the stomach to produce acid, and it also regulates hunger. So when the vagus nerve is cut, like what is done in vagotomy, the stomach produces less acid, and patients will now experience reduced feelings of hunger. So in short, it is performed to help with weight loss. Another method to stimulate gastric production is what we call as the sham feeding. So the sham feeding is the last method for gastric acid stimulation. It is also known as the fictitious feeding. So when we say fictitious, it means false or fake or not true feeding. So in this process, the patient will eat sandwich and the patient will chew the sandwich thoroughly. So after chewing, the patient will spit it out. So the purpose of this is that while the food is chewed, the stomach senses the food in the mouth and it begins to prepare for digestion. So it releases acids. However, to avoid food particles during aspiration, the food is spat out after the stomach has released the acids. So essentially, it is like teasing the stomach. So, pinaasa si stomach. Okay? So, we have discussed earlier the bow and the mao. Here we have the bow-mao ratio. So, the formula for bow-mao ratio is just the bow divided by the mao times or multiplied by 100. So, in pernicious anemia, the ratio for bow-mao is 0 because there is no production of acid or no HCl in pernicious anemia. While in ZES, the Baumol ratio is markedly increased because of the tumor that releases gastrin, causing more acid to be produced. Okay, so just an additional information, we have Diagnex tubeless test, which is a test for free HCl. So, question, what do you think is the specimen used in Diagnex tubeless test? Is it blood? Is it urine, stool, or gastric fluid? So I know you answered gastric fluid because it's our topic, right? But if gastric fluid is your answer, then you are wrong. So notice that the test says tubeless test, meaning no tube is inserted for collection of sample. So that is not gastric fluid. So what could it be? The specimen used here is urine. So this test utilizes the azure blue or azure A, which are stains in granule form. So in the procedure, the patient eats the stain and then drinks water. If the stain is present in the urine, turning it blue, this indicates that HCl is still stored in the stomach, meaning the stomach still produces acid. On the other hand, if the urine does not turn blue, it suggests that there are no acid stores in the stomach. Okay? So again, it is called tubeless because there's no need to insert a tube or perform gastric aspiration to determine whether the stomach has acid stores. The principle is just very simple. If the urine is blue, it indicates that acid stores are present in the stomach. Okay, so this is a very short discussion. That is the end of gastric fluid topic. Now let us have a quick review. What is the normal color of the gastric fluid? Okay, the answer is B, pale gray mucoid. Next, gastric tube that is inserted through the nose. The answer is Levin. Remember, nose has letter N, Levin has letter N. Next, no HCl. The answer is B, pernicious anemia. Next, increased gastrin and HCl. The answer is A, ZES. The Baumol ratio in pernicious anemia. The answer is B, 0, because there is no HCl or no acid in pernicious anemia. Why is there no acid in pernicious anemia? Because the antiparietal cell antibody destroys parietal cells, which produces HCl. What is the specimen used in Diagnex tubeless test? We just discussed this. Okay, the answer is urine. What is the term used in pernicious anemia that means failure to produce acid following gastric stimulation, meaning the pH is always greater than 6? Anacidity. Okay, so that ends our discussion about the gastric fluid. Thank you for listening.